I just want to talk about community quickly. So this is something so important. This is where organizations have their true value. This is where having a network of true friends. Thank you, Alexis. She's our CEO, and she's created this whole place. Thank you, Alexis. Having a community is so important, so I appreciate that call out for community and echo that.
So before you go on, I just want to acknowledge Dr. Chapman, and also this being our keynote seminal lecture, and it's going to tie a lot of principles that we have elucidated over the last few hours and also a few days. We're truly grateful for this honor, and please take it away, Dr. Chapman.
Thank you for the kind words. Totally undeserved. Facts will be for you to decide, but I appreciate the call out. Cervical thoracic junction, why is it special? For me, this is the actually more important and much overlooked alignment challenge that we face as human beings. Yes, of course, all of you have been indoctrinated with the ISSG numbers for the lumbosacral junction and the TL spine. But in fact, the cervical thoracic junction is the culminating point that articulates our cranium to the rest of the torso. And in fact, is more vulnerable to imbalance, which is highly problematic for us. So I hope to convey to you the spectrum of complexities of the CT junction, approach concerns, and surgical stabilization. And as always, no surprise to those who know me, I have a pretty clear answer and suggestions. Wake-up question, how many vertebrae does a giraffe have? I'll call out some of my guys. Mohammed, a number. How many? Number. Why Jeremiah? Jeremiah from Nairobi knew it. 7. Why is that? You're from Kenya. You're fantastic. Why is 7 the proper number? All mammals have 7. The blue whale down to the little mouse has 7 neck vertebrae. And that junction of the neck to the thoracic spine is a critical failure point. So this is the same thing for all, and these are giraffes that are exposed to this. And interestingly, those who are more upright have a bigger exposure to this. It's called encephalization. So we have a larger brain, but this puts the onus of mechanical stress on the cervical thoracic junction, which is defined as between C6 and T3. That's the true CT junction, and that's a great interplay of osseous and ligamentous anatomy. So prevention of problems and treatments are critical here. And all of us are subject, and as an aging guy, probably the senior person in this whole audience here, we're subjected to this loss of alignment. So if I can ask all of you, not to drop your pens, klutz move, but to be physiologists, biomechanical physiologists, prophets of alignment. I want you to leave here as prophets of alignment. Alignment, ears, shoulders, hips, ankles. Whether you're neurosurgeons or orthopedic surgeons, alignment. And old or age is not an excuse for poor alignment. Be prophets of this, really put it, the spine is an organ, and it should be part of basically organ health. So bad posture is an anathema towards a successful spine. And not chastising your patients, but trying to find productive ways to counter this is critical so that patients literally understand the importance of having strong, yes, neurosurgeons, shoulders, supraspinatus muscles, and not succumbing to a dowager's hump is so critical. And yes, gravity sucks, but that's why we have muscles for it. That's why we have a brain in our shoulders. And these secondary impacts are brutal. Pain, mobility, swallowing, falls, second leading cause of death now in America. Neurologic dysfunction, all a sequelae of the CT junction failure. And one more time, it is a well-known physiologic phenomenon. As we age, our spine wants to fall forwards. We fall into kyphosis. In my practice, where I see successes and failures of aging, and I obviously try to learn from every patient all the time, I see 90-year-olds who look brilliant. Guess what they all have? They have the ears over their shoulders, and they have strong muscles, and they exercise for that. Yes, as we age, we have to work on balance and strength. So one other plea along this line is analogous. I don't know why we surrendered the field of physiologic rehabilitation to rehabilitation doctors and PTs. I'm super critical about PTs. I'm very specific of what I want them to do. I don't want some craniosacral whatever juju they do in Maryland or in other places. I don't want that. Or in LA. Hey, I'm talking to my LA colleagues here. I want specific things, and I want the PTs to execute those things. And otherwise, I will not send them patients. We should be the best rehab doctors. This is not rocket science. For all you brilliant minds here, this is not rocket science. This is basic common sense, and it's not that time efficacious. You can do this. Yes, you, and you, wherever you come from. How heavy is your head? That's another trivia question, like the 7 neck vertebra. 12 pounds, roughly. In my case, with my hydrocephalus, Rod, how heavy is my head? 20, right? But good posture is good. The more you lean forwards, the worse it gets. It doubles or triples your effective weight. Mechanics are important. And no, those gadgets don't work, but what really works is a strong trap and strong supraspinatus muscles. And guess what I do? Here's Ben right next to me. Ben, can I approach you? Hi, Ben, how are you? Guess what I just did? I checked his sarcopenia or absence out. I checked his supraspinatus muscles and the previous one friendly motion. That little grip identified this person has a healthy shoulder girdle. And if that's not the case, that's a SAG risk patient. Diagnostics. In the era of C-spine x-rays, especially in larger shoulder people, we forgot about the CT junction. This is an actual case of mine at Harborview where the general surgeons were worried about why is this patient not doing well? Well, this patient got the head trapped in a dumpster and ripped the head off. This is a true case, okay? This is in the older era where we relied on x-rays rather than CTs. So this shouldn't happen anymore, but x-rays are not helpful for the CT junction. However you do it, and that goes to intraoperative fluoroscopy unless you have some magicians like what we're blessed here with. So this is all well known, and yes, we all know obliques or pull downs and yada, yada, yada. Larger patients are a big problem, and there's a diagnostic uncertainty in this as we still rely on plain radiology. So this is a really big deal, and injuries can be missed. And again, in this era of CTs, this should be a non-factor, but the cuts have to go down to the true cervical thoracic bottom junction, which is T3, or they should go to the cranium for the craniocervical junction. Different topic. So this is a really big thing. Oh, I forgot one thing. Use the CTs and tell your techs to give you the manubrium. If you were to decide on an anterior approach, you want to know what the vertebro-manubrial entry angle is. There are people who have a very high manubrium relative to their C-spine, and I suggest not to try to do an anterior surgery there. On the other hand, you have these swan neck ballerina type people who have a beautifully long giraffe neck, here's the animal analogy again, where you can get down to T2 or T3 if you were to want to do that. I'm going to make a case against that. Manubrial vertebral entry angle, you should see it on a CT. So don't miss injuries. And again, MRIs can be cut off at the cervical thoracic junction, unexplained neurodeficits, ligament injuries, hematomas. This should not be rocket science. You want to check for cord signal changes in the pattern, especially Bijan Arabi, who is frequently here for our spine trauma course. Don't miss it in December. The length of the cord signal changes is what matters most. He has great papers and longitudinal papers on this. He's one of our visionaries, and for some reason he gets to order MRI scans on a daily basis. If I ordered 2 MRIs on a patient, boy, I get problems with the insurance companies. I want to shout out also to Chris Ames at UCSF. He gave us, I think, next to the S1 inclination angle, the single most important angle, and this is the T2 vertebra. The importance of the inclination angle, I put that routine into my things next to the SVA, is so critical. Dr. Skaggs, he applauds the T2 angle importance also. It'll be in T2 in the ortho bullets this afternoon. T2 inclination angle, not a big description of those now. You can all read that up. So things to look for is when we have a cervical thoracic or a subaxial kyphosis, we develop what we call Bazem sign. Bazem Ishak is a former research fellow of ours. He's now professor of neurosurgery in Heidelberg. The C1 arch will compensate on C2 for a cervical thoracic junction or a subaxial kyphosis. So look for that next time when you see a hypertrophied posterior arch of C1. That patient is compensating with a craniocervical junction on the subaxial kyphosis. And that, yes, can create secondary constrictions like this. So the focus is not the kyphosis. The focus here is on C1, C2, and the patient's impaction on the upper cord level. Treatment, again, non-operative junctions are highly frustrating. The halo is a very problematic device because of the distress extraction device, but what matters most is torso fit. And this is pretty much an anachronism. I wrote several big papers on halos. I love them. I've really not used them anymore. Patients don't like them. The rumors out there in the streets that it's no longer cool, although Dr. Skaggs, with his incredible practice, will make a strong pitch for craniopelvic traction in certain younger patients. So big deal, but ligamentous injuries and C71 happens to be the single worst stability level for external immobilization. Snaking and distracting are the key words. Surgery, to quote the famous Dr. Yankovic, what should I do? It's a big problem because this is a real opportunity to screw up patients. In a quick point, I'm going to flash through anterior slides. I'm going to make a pitch not to do that. Upper thoracotomies or low anterior neck exposures, highly questionable, highly problematic, highly disfiguring, highly disliked by patients. There's no good way to do a manubrial split. I've done all these things, or sternoclavicular dissociations. That's tumor surgery. That's radical. That's an anachronism. This is not a good procedure to do unless there's some very unusual things to do. And your chances to at least butcher up, and here's that word again, the patient's ability to phonate, which is not dysphagia, but dysphagia, or can lead to dysphonia. So this distinction, slowing point, by hitting the recurrent laryngeal nerve or stretching it or burning it to pieces, is a real opportunity. So lower neck approaches from the front are a really problematic thing. And take it from me, I've done these things. I've failed patients. I've had Dr. Lord must have listened in on my OR. These situations may go like OSHIT. And not good, okay? Manubrial entry angle, again, in your pre-op planning, if you were to want to do a lower C-spine or cervical thoracic approach, like a graft or something like that, learn where the manubrium is and don't split it and don't take the clavicle down. Upper thoracotomies are subscapular procedures. Again, if you want to denervate a scapula and have a winging scapula afterwards, you do an upper thoracic exposure through an upper thoracotomy. No fun. Completely irrelevant nowadays. Anterior plating, mechanically highly problematic because guess what? Our upper vertebral bodies of T1 through T3 are hypodense. Why is that? Because the ribs are very strong there, so the costovertebral articulations offload the vertebral body substance, and there's an incremental difference. Measured next time you're in clinic with Hounsfield unit measurements, our eye circles, there's an incremental difference between C1, T1, and T2. You can measure it in your own clinics next time. Don't do anterior platings there because you'll get this kind of really bad outcome with complex failures that you then get to re-explore as a surgeon. So this is just no good and no good and no good. Posterior is the way to go. Mechanically, it's the tension side. You all know that. And we all struggled with adopting the unique cervical anatomy to the upper thoracic anatomy with whatever hardware systems we used. Yes, our fellows actually get to do a hooks and cables lab because I want them to be well versatile in these techniques. Maybe we should do a formal course and you come join us and learn how to do hooks and cables from a dinosaur. I think you don't need image guidance for this. You need good hands and good technique for this. And no, you're not going to have to do this crazy construct that I did many years ago. So this is not relevant, but knowing how to do these things is important, but it's a bailout and it's a supplemental fixation strategy nowadays. Obviously, anatomic parameters of posterior fixation are highly relevant. We published on it way back in 1994, and back then that was a revolution. Every one of those screws was put in with the greatest deal of trepidation. It was a victory when everything went well. Very challenging because of the discontinuity of thoracic pedicle screws and cervical lateral masses. So that offset is not simple. The landmarks of this are actually really simple. You have to have a 3D sense of anatomy. I study my CTs. Our fellows know how to do a high-tech thing of penciling out, actually drawing with felt pens through a paper, the alignment. It's reasonably precise. And knowing your starting spots is simple. Take the TP down. You have GOD gave you a perfect starting spot, and yes, image technology helps a little bit, but knowing your alignments level by level is a really cool thing to do. And again, screws nowadays are a very good rigid way to do. I lost, declaration to all of you, this quote, excellent surgeon. I lost a patient due to a C7 pedicle screw within the last 2 years from a vertebral artery injury and a highly aberrant anatomy that I thought I had well managed. So this is still an unforgiving area. Now to one of the key things to remember, aside from the fact that nobody's perfect, and understanding the anatomy and vertebral artery anatomy for C7 specifically is a soft tissue trap. So this is not just an osseous challenge, this is a soft tissue thing I tried to emphasize with my rehab pitch before. This is a high tension area, and these are all patients that have had somewhat or not indicated surgeries, or sometimes well indicated surgeries, where there was a completely avoidable mistake made. Kojo, since you gave me the shout out and wearing that cool one spine shirt, what is the avoidable mistake that every one of those surgeons made?
Muscle approximation takedown.
Almost correct.
Yes.
Soft tissues, soft tissues, soft tissues. When we're done with our instrumentation, we've avoided all the complications, we go, yes, done. Gloves off, out. This is a problem. Trapezius winging, the so-called delta sign, dehiscence is unpublished or underpublished and a real problem for posterior cervical thoracic things. In fact, for anything where you go into the lower C-spine, this is a high tension area. This is a true fascia. So that's the one addendum I would make. This is a truly relevant fascia at a high stress point. We have to repair those. I recommend delineating the fascia preoperatively and then making an effort. And if you're too tired, call on a colleague. Use general surgery principles. You have to get the true fascial closure. What I see frequently done is 1 or 2 good fascia stitches go in, especially in larger patients. The soft tissues collapse, the fat goes in, and then the next stitches are all in the fat, which does not hold. Use slow, I'm not going to give a product shout out here, but slow resorption sutures. I use a certain product that you see down here, and you can do your own reading. And I tag sutures. So I ask the fellows usually, after showing it once or twice, to tag figure of 8 sutures. So you put snaps on each suture, and then you tie them at the very end. That way you have a true fascial closure. Or you can make the skin incision long and use general surgery principles of a doubled, looped suture. But the true fascial closure is absolutely quintessential. And you want to have sutures that stay in for hopefully about 6 weeks or so. Or if you have non-compliant patients, you use a shoulder strap like orthopedic surgery residents know what that is. That's a clavicle strap. So high tension area, avoid this avoidable pitfall. Okay, so what to do? How do we approach this? Anterior, posterior, posterior, anterior. What's the thing? We have a variety of scenarios, and we can do it for whatever we have. Post-traumatic, so late C6-7 kyphosis, cervical thoracic junction. This is a complicated case. It's fortunately a little bit higher. So anterior release, posterior osteotomy, anterior graft. This is a painful non-union. This is exactly what we did. And we had our manubrial entry angle assessed. This is very doable. Infection. This patient was actually bounced around the country. This was a physician who had Pott's disease, upper thoracic spine, I think it was T2, and multiple people wanted to basically approach her with anterior-posterior procedures. We went from posterior only, did this. She actually recently came back for like a 20-year follow-up and has had a brilliant career and family and everything like that. And this was done through a single root ligation at T2 at the cervical thoracic junction. There's nothing brilliant about that. It's simply study of the anatomy and understanding your neural dissection and realigning the spine. Degenerative, very common cause for problems. Upper cervical, now you see the pattern, the phenotypical approach, upper thoracic kyphosis, and is compensated by the upper cervical spine with posterior redundancy of ligamentum flavum or impingement of the C1, C2 junction. So it's a chain reaction. We corrected the cervical thoracic junction with a corrective osteotomy and did a laminoplasty at the top. This is actually like a 20-30 outcome. The patient gave me a authorization to do this, and he actually wrote a song for me. So it's somewhere out there. But he loved it. He loved being mobile, and yeah, he was disabled by what looked like a kind of like a dowager hump in the male version. Transition breakdown, very common. Caudal failure in an at-risk patient, so don't stop a fusion in an at-risk patient at C7. Going down to T2 or T3 is way better. This was a nightmare to take care of, and it was feebly done. Here again, we went anteriorly posterior, but we did posterior. We did an anterior release, posterior fusion, and then a anterior supplementation. Nowadays, I would not use these anti-kickout plates, and I don't like metallic cages, especially in at-risk patients. I like allografts, but this is what I did back then, and she was actually very happy, and the deformity reduction allows to repair the soft tissues. Post-laminectomy syndrome, believe it or not, this is something that we still struggle with, and Dr. Screen was so kind to send me a horrible case of a post-laminectomy kyphosis that he did not do, but we'll do this together in the near future. And these are very challenging things because these swan necks should simply not exist. Rather do a fusion, but again, here we did an anterior-posterior reconstruction. The anterior part was again just a release and then a full supplementation. What I've really come down to nowadays is staying as posterior as I can. So it's a more complex step ladder, C-spine, We did an anterior multi-level ACDF, no hardware necessary with modern allografts. And then we did a posterior osteotomy and basically straightened out the patient through intradiscal osteotomies, which is a very elegant technique that allows you to fully straighten out the neck again. And again, this is a case that we just did actually last month, just before the last fellows came in. Again, the same topic, T2, T3 failure. For some reason, the surgeons put a single T2 screw in this patient. The patient fractured, was severely disabled with this. And yes, we did intradiscal osteotomies by cutting the spinal column very carefully. We were prepared for 3. We got a very nice realignment with 2. And of course, this patient is at a high risk for caudal failure. You could argue, and we have many of these discussions in our various SSF fora, to actually go to L1 primarily, but at this point in time, I stopped at T11, and we'll see how she does. So CT junction, high stress area, maybe the single most relevant area in terms of failure propensity of patients in our deformity era. We have great tools to measure this and visualize this. We have to really pay heed to the biomechanics of this area. Anterior column support may be necessary. Try to do it from posterior if you can save critical roots. Posterior tension band reconstruction with rigid fixation is necessary. It's still a dangerous territory, as I told you with my C7 disclosure, and it's a really big deal to repair the soft tissues properly. Nutritional support is relevant, and again, going anteriorly below T1 is really an issue. Try to use costotransectomies. Thanks for this. Kojo, was that okay?
I think that was spectacular.
I love you. I love you.
I love you too.
With this, unless there are other comments, go to lunch.
No, it's a break.
Break time.
Thank you.
And we're coming back when, Kojo?
In 10
You be the boss. In 10 minutes.
10 minutes.
Kojo.